Nephrology Fellowship has been very unique in each aspect because of the multidisciplinary team approach, and it opened our eyes not only for the nephrology training and education, but also for the critical care education. Today, we are not only celebrating the graduation of our fellows, but also the achievements of our dedicated tutors and board members whose steadfast support and hard work have been instrumental in shaping our fellows' success. To our esteemed tutors, well-respected board members, your patience, your passion have profoundly impacted our fellows' performance and journey. And we are sincerely grateful for everyone and each one and every single one of our tutors. It has been over 18 months now since we started meeting together, brainstorming, critical thinking, and structuring and creating our unique critical care program with more than 230 fellows from 36 countries. Behind every proud graduate today from our fellowship program stands a tutor whose unremitting efforts and encouragement and positive energy and positive influence have guided our graduates in every single step the way. Thank you so much for your extraordinary efforts. My dear colleague, Dr. Khalid Al-Suwaifi, a critical care physician in Saudi Arabia in the Eastern Province, Dr. Ricardo Matas from Portugal, very well-known critical care physician, Dr. Ashraf Tayyar, very known BOCAS expert, Dr. Marcos Broman, very well-known Swedish critical care physician who's practicing in United Arab Emirates, Dr. Craig Ernst from South Africa, whose his work in our group and education was unstoppable. Dr. Rola Othman, her contribution and communication and collaboration in this program was extraordinary. Dr. Jacob Bakrizia from Spain, who works in Portugal, he's a critical care physician, and also his contribution was unprecedented. So thank you so much, our tutor board member, for this very successful program. Today, I'm going to give you a very brief example how we should work as multidisciplinary team and team player to improve our patients' outcome. And I'm going just to give a very small example of fluid management. Fluid is very important, pivotal step in improvement our patients' outcome, especially in critically ill patients who need resuscitation. The European Society of Intensive Care Medicine, the ESCOM, has published a couple guidelines this year in 2025 for treating and resuscitating our critical ill patients using fluid management. So as you know, that water constitutes about 60–70% of our body. So the water balance is very essential. So they came in with 3 publications, 3 different guidelines, because they cannot do this in a single publication. So the clinical practice guidelines has been divided into 3 parts. The first part was about the type of fluid: crystalloid, colloid, lactate ringer, saline, glucose-based solution, whatever the kind of fluid we need to give to resuscitate our patient. Part 2 was published 2 months ago, and it was about the amount of fluid we should give, the volume of fluid. Part 3, we are waiting for it, and it will be focusing on fluid removal and the de-escalation phase. As you know, all of our patients' electrolyte derangements that happen in the critical care settings is associated with a severe imbalance in the water. So if you have a patient with hyponatremia, it's not a problem with the sodium. It's usually a problem with excess water. And if you have a patient with hypernatremia, the opposite happen. So, the fluid management, fluid assessment is very, very essential. As we know that resuscitation, there is 4 stages and phases of resuscitation. The first one is the initial resuscitation phase when you are encountered with a sick patient, hypotensive, shocked patient, and you need to resuscitate. Then you need to optimize this patient management, usually after 3 to 6 hours of initial resuscitation. Then you need to stabilize this patient. Then later on, down the road, couple days, you need to de-escalate this fluid. You need to decongest the patient because initially you give a lot of fluids, and now it's a time to try to remove some of these fluids. So the ESCOM, the European Society of Intensive Care Medicine, tried to answer these 10 questions. I just, summed them up to 8 to make it easier for you. And the first question was, should 30 ml per kilogram fluid volume be used for initial resuscitation for every single patient who is critically ill with septic shock? And is it yes or no? Just simple answer. Say yes or no. 30 ml per kg. So if you have a patient, 80 kilograms or so, you probably need to give about 2.4, 2.5 liter of fluid. I'm just going to give you some questions at the beginning for critical thinking and the brainstorming. Then I'm going to discuss the answer later. Question 2, the ESCOM came in with this question. Should a liberal or a restrictive strategy be used in the optimization phase of resuscitation in patients with septic shock? Should we be liberal or restrictive? What do you think? Well, think about it, and I'm going to help you to answer these questions shortly. Okay, let's move on to question 3. Should an individualized approach, personalized approach, be used in the optimization phase? So again, we are not talking about the initial resuscitation phase. We are talking about the second phase, which is the optimization phase of resuscitation. And here we have a patient with septic shock. Should we use individualized approach, or should we give all the patients the same fluid amount, whatever 20, 10, or 30 ml per kg per hour? And the answer is just yes or no. And I'm going to come up shortly with answers. Then question number 4, should a restrictive or a liberal strategy be used in patients with hemorrhagic shock? Should we be liberal or restrictive? What do you think? Again, think about it very, very, deep, and try to dive, because here it's either to improve your patient outcome or your patient might have a devastating consequences if you don't treat your patients in a precise and proper way. Okay, let's move on to question number 5. And the question is, should a restrictive or a liberal strategy be used for circulatory failure in a patient with pulmonary embolism? So you have a patient with pulmonary embolism and probably right-sided heart failure. Should we give a lot of fluid and be liberal in fluid management, or should we be more restrictive? Okay, let's move on to question number 6. And this question is about patient with cardiac tamponade. And the question is, should a restrictive or a liberal strategy be used in patients with cardiac tamponade? Okay, let's move on to question number 7. should a restrictive or a liberal strategy be used for patients with left-sided heart failure and cardiogenic shock? So we talked about pulmonary embolism and right-sided heart failure. Now we are talking about left-sided cardiogenic shock. Should we be restrictive or liberal? The last question I have for you and for myself and for every single physician, because this is not a nephrology, this is not a critical care. Every single healthcare professional should understand the basics of fluid management, because it's very essential in our patients' treatments and management and outcome. And the question is, should a restrictive or liberal strategy be used for patients with adult respiratory distress syndrome? So, liberal or conservative? Do you want to be liberal in this patient with ARDS and shock, or do you want to be restrictive? Let's try to answer this question. So the question number one here is what the SCOM said. So do we need to give 30 ml per kg for fluid resuscitation in the initial phase? They suggested giving the 30 ml per kg of IV crystalloids, and of course not colloids, in the initial phase. And this is when you don't have any hemodynamic monitoring, usually in the first 3 hours, with adjustment based on clinical context and frequent reassessment. So yes, vote for 30 ml. Every single patient, when you see, you don't know if this patient have what kind of shock. Is it only septic shock or combined with left ventricular dysfunction, cardiogenic shock, any other kind of distributive shock or others? Give fluid. Give at least a couple liters of fluid in the initial phase when you see the patient in the ER or patient just moved to the ICU. For the question number two about the restrictive or liberal approach in the optimization phase, not in the initial resuscitation phase, in patient with septic shock, they said they cannot recommend for or against systematic restrictive or liberal fluid administration. So the answer is we don't have a good answer for this. So they kept it up to you to be either restrictive or liberal, maybe to use the individualized or the personalized approach, but there is no size that fits all here. For the third question about the individualized approach to be used or optimized in the optimization phase of septic shock, they suggested using individualized approach. Again, no single size fits all. We have to optimize, individualize, and personalize your treatment. And here in the optimization phase, you should have at least some hemodynamic monitoring. Maybe you have CVB, maybe you have a BOCUS, point of care ultrasound, which we are emphasizing and encouraging every single physician to have at least basic skills, how to handle the probe of the point of care ultrasound, to assess the volume status, to see if the patient has pericardial effusion for the soft tissue, and so on. So it's very essential in the optimization phase after 3 to 6 hours to use individualized approach, not every patient to be treated the same. Then the answer for patients with hemorrhagic shock, they divided these patients actually depending on the type of hemorrhagic shock, that because of trauma and which kind of trauma, penetrating or blunt trauma or non-traumatic hemorrhagic shock. And they said we need to be restrictive in giving fluids for patients with penetrating trauma or blunt trauma, because we have to allow for a permissive hypotension. Permissive hypotension is not bad. You can keep this patient with penetrating or blunt trauma because there is a compensatory mechanism that can happen. So you can keep him in the lower blood pressure side. This shouldn't be a problem. And the fluid administration should be guided by hemodynamic and biochemical biomarkers. The question number 5, in patients with pulmonary embolism, they said clinicians should be cautious about giving fluids and the management of fluid should be based on their decision or measuring surrogate markers of right-sided heart failure and systemic congestion. In patients with cardiac tamponade, they said fluid should be given cautiously as a temporary measure, just as a temporary, not a definitive measure, until definitive management can be undertaken, like if you want to tab this pericardial effusion that induced cardiac tamponade. For patients with left-sided heart failure and cardiogenic shock, they ungraded the evidence. They went down on the evidence. They ungraded best practice statement, and they said fluid resuscitation should not be the primary treatment. This, evidence is not good. So they didn't recommend that for every single patient with cardiogenic shock, you need to be restrictive. Again, individualized approach. The last question, in patient with ARDS, they said they cannot make a recommendation about the volume of fluid administration. Should we be restrictive or liberal? They cannot give guidelines because the studies that has been conducted in ARDS patient wasn't consistent. Again, this is a brainstorming, a critical thinking. And the last question for you, why the ISCOM, why the European Society of Intensive Care Medicine clinical practice guidelines has more suggestions than recommendation? Why the 2025 clinical practice guidelines, the grades and level of evidence went down, not up? Don't we have more well-designed studies to answer our question? And I'm just going to leave you with this, because for a long time we thought that our confidence is parallel with our knowledge. When you increase our knowledge, we increase our confidence. But there is two clinical psychologists, Justin Kruger and David Dunning, try to test this hypothesis and see the relationship between the confidence and the skills. And what they demonstrated that if you have an ignorant, people and you give them some information, their confidence goes up to the ceiling, up to the roof, very high. Then if you give them more and more information, if you teach them, they'll be more humble. Actually, their level of confidence goes down. And you give them more, you teach them more, and their level of confidence goes down. Then start to go up a little bit when they become, more and more knowledgeable. And even the experts, their level of confidence is still, very low compared to those who knows little, who were given just very few information. So we need to get more information. And this information has no value unless we put it in practice. Our aim in the World Kidney Academy is not to give you information or knowledge, but actually to help you to apply this information to improve the standard of care, the patient outcome. So the great aim of education is not the knowledge, but the action. And with that, I'm going to leave you with the walk of honor, and we are going to see our fellows graduating, and we are going to see the speech that you have given and your pictures and the name in the screen right now.